Hey guys, my name's Sharone and I'm a PA in orthopedic surgery. And today we're going to be talking about meniscus tears. So this is the second video of my three-part video series. And like I said, today we're going to be talking about meniscus tears. So if you guys want to learn a little bit more about knee arthritis or ACL tears, go ahead and check out my other two videos where I talk about those very common conditions as well. Also, just as a disclaimer, if you are experiencing pain or have had an injury to your knee, this video should not supplement you from seeking professional medical advice. This video is for educational purposes only. Okay, so before we talk about how meniscus tears commonly present to clinic, let's talk a little bit more about what the meniscus is and what its function is in the knee. So in each of your knees, you have two meniscus. You have your medial meniscus, which is a little bigger, and your lateral meniscus on the outside of your knee. So the meniscus is a C-shaped cartilage ring that lies inside the joint. Its primary function is to be a shock absorber to the knee. So what I mean by that is when you're running or you're twisting, the meniscus absorbs the pressure and distributes it more evenly throughout the knee joint. It also functions and plays a role in stability to the knee. So it acts kind of like a suction cup between the femur and the tibia, providing some source of stability to the knee as well. It also provides a joint lubrication to the knee. So when you're twisting or you're pivoting, it provides a smooth gliding surface to the knee joint. So meniscus tears can present pretty differently to clinic depending on the patient's age. So in your younger patients, usually they've sustained an acute injury to the knee. And as a clinician, you're trying to typically differentiate between a meniscus tear and or possibly a ligamentous injury. And then in your elder patients, usually they don't have an injury. However, they have had chronic pain or insidious onset pain, or possibly they overdid themselves one day. And as a clinician, you're trying to differentiate typically between arthritis and or meniscus degeneration or tear. So with that being said, let's look at our first scenario. So our first patient is a 33-year-old male who presents to clinic with sudden onset left knee pain. He states that the pain started acutely 2 days ago while lifting a heavy table. He states that he heard a pop and experienced sudden onset pain over his medial knee. Swelling and stiffness developed the next morning. He's ambulating with crutches due to the pain. He denies any catching, locking, and instability. So in orthopedics, it's very important to always ask your patients, especially in acute injuries to the knee, are you experiencing any catching, locking, or instability? So catching and locking typically cues the provider into a meniscus tear or meniscus etiology, and instability is more so for a ligamentous injury. However, like we talked about, the meniscus does play some of a role in knee stability. So if a patient does endorse instability, it's something to think about. However, instability is more commonly thought of as a ligamentous injury. Okay, so let's look a little more deeply at the history. So this patient's injury was when he was lifting a heavy table. So what this patient was doing was loading pressure onto the joint, and he may have twisted his knee at that time. Commonly, meniscus tears are experienced when a patient is running or putting pressure on the joint and twisting or pinching the meniscus and pivoting. So that's commonly seen in sports. So sporting injuries are common causes of a meniscus tear, particularly soccer or skiing. However, I wanted to provide you guys with this scenario so that you're thinking about other ways to load pressure onto the joint and also pinch and possibly tear the meniscus. Also, this patient states that he heard a pop. So I always ask my patients with acute onset knee pain if they heard a pop at the injury. So usually I think about ligamentous tears if a patient hears a pop, but it's not uncommon for patients that have sustained a meniscus tear to also endorse hearing a pop. So you shouldn't rule out a meniscus tear if a patient does hear a pop during the injury. Next, very, very, very important piece of history to gather is, were you able to continue with the activity for the remainder of the day, or did you have to stop? Commonly, patients with meniscus tears, they can continue with the activity for the remainder of the day. And then usually swelling and pain develop later on in the day or the following day or days, versus a ligamentous injury where a patient has an acute injury and they are out for the remainder of the day. And swelling typically develops immediately or within a couple hours, an hour or two after the injury. So different pictures and a very important piece of history to gather regarding the acute knee injury. Then it's important to note that this patient's ambulating with crutches. So when we asked him if he's having any catching, locking, or instability, he's not really going to provide us with a reliable history regarding that. Okay, so next we have our middle-aged or elder patient. So 46-year-old male presents to clinic with insidious onset left knee pain. He states that he had gone on a hike several days ago, and the following day he woke up with pain and swelling in his knee. He denies any known injury and endorses catching and clicking in his knee, no instability. So what this picture is depicting is that this patient has not had an injury to the knee. However, it sounds like he kind of overdid himself hiking. So that's more common to see in your middle-aged or elder patients. And again, very important to note that that pain and the swelling develop the next day. So again, that's highlighting how important of a history that is to gather in these patients. And then in terms of symptoms, this patient's endorsing catching and clicking. So it's not uncommon for patients to not really know how to describe the catching sensation, and sometimes they'll say clicking. So if this occurs, I'll kind of slow down and ask my patient. So in terms of clicking, what I mean by catching is that when you bend your knee backwards and you extend it forwards, do you feel like there's a mechanical or a block in your motion of your knee, kind of preventing you from bending and extending your knee out? And typically, patients will kind of pause after you say this and think about it and be able to provide you with a better, more reliable history and say, oh yeah, that clicking is actually catching. So that's important for you to clarify with your patients as well. Usually in acute onset meniscus tears, your differential can be pretty wide. So typically, I'll be thinking about meniscus tear, ligamentous injury, so possibly ACL or PCL, also MCL or LCL too, versus possibly an IT band pain or syndrome and or pes bursitis or hamstring strain. And then your elderly patients, you're thinking more about degeneration, arthritis as well. Okay, so you guys gathered all the history and now it's time to move on to the physical exam. So very important to inspect because the inspection kind of cues you into the severity of the injury. So when I inspect my patients, I'm looking to see their knee and if there is a visible effusion. You want to assess, is the effusion large? If it's large, you're thinking more about a ligamentous injury and or possibly a fracture. So even an occult fracture that maybe the x-rays didn't pick up. And then if the effusion is more mild or not too visible, then that's when I'm thinking more about the meniscus typically. You also want to inspect to see, is the patient able to weight bear or are they using crutches? It can really vary in meniscus tears. And then are they ambulating with an intalgic gait or limping, or are they able to fully weight bear? So all very important things to see and note regarding the severity of the injury. So then we're going to move on to palpation. So ask your patient, where do you feel the pain? So if they are able to localize the pain and they say, oh, it hurts over the inside of my knee, make sure that you palpate the joint line. So joint line tenderness is a really sensitive finding on exam for meniscus tears. And it's a common finding that you'll see and really cue you into having a patient having a meniscus tear. You also want to make sure that you're palpating above the joint line, which can cue you into maybe more of an MCL tear, or below the joint line, which also you can think of MCL tear versus possibly hamstring or pes bursitis if it's more on the inside, lower middle part of the knee. And then on the outside of the knee, joint line, you want to palpate again versus above or below with a LCL injury or possibly IT band syndrome over Gertie's tubercle. Very important to palpate the joint line and see if that elicits pain. Then again, you want to look at your range of motion. So range of motion is really important for two different reasons. One, you want to assess this to see how severe the injury was. If the patient presents in their range of motions about 5 to like 45, it's not really all that great. So you're thinking the injury was a little more severe. And versus maybe your elder patient has full range of motion, 0 to 120 plus. So it cues you into the severity of the injury. Also, you want to document it and track it to make sure that the range of motion is improving, especially in your patients where maybe you're thinking about surgery. So preoperative range of motion is a very important indicator and prognostic factor for postoperative range of motion. So you want to make sure that the patient's range of motion is improving so that their post-surgical recovery is going to be speedy and a lot easier, and also that they're ready for surgery. Also, you want to make sure that the patient's knee doesn't become stiff. So if their range of motion is really limited and it stays limited, that knee can become stiff. So that's important to note. So special tests. You really want to make sure you test that ligament and the ligament laxity on exam to rule out any ligamentous injury. So you want to make sure you do your anterior drawer, your posterior drawer, and your Lockman, as well as testing your MCL and your LCL with varus and valgus stress to really examine to see if there's any laxity with those ligaments. And if there is, you have to, be more suspicious for a ligament injury. Very important to test your ligaments and rule out any ligament injury in your acute knee pain patients. Otherwise, the tests that are more sensitive for testing your meniscus are going to be your McMurray, your Apley, and your Thessaly. Particularly, I think the McMurray and the Thessaly are more sensitive for picking up a meniscus tear, but that's kind of what I find. And then in my kids, I like to ask them to duck walk. So what that is, I'll tell them to kind of squat down, flex their knees, and then waddle forward. And I'll ask them, are you experiencing any pain or any catching with that? And usually they'll respond a little bit better to this kind of playful like physical exam maneuver. So in terms of doing the McMurray, you can do this with the patient sitting upright or supine lying down on the exam bed. And you'll have their knee flexed to 90 degrees. And so what you'll do is you will take the affected knee at 90 degrees and you'll externally rotate the foot and put valgus stress on the outside and slowly extend the knee up and ask your patient if that elicits pain or if they experience catching or locking with that. That's going to test the medial meniscus when you do that. And then you're going to do the opposite where you internally rotate the lower extremity foot and place varus stress on the inside of the knee with the knee bent at 90 degrees and then slowly extend the knee up and test your lateral meniscus with that maneuver. So again, asking your patient if they feel any pain or catching or locking. And what you can do is you can compare it to the contralateral side to kind of see how sensitive that exam was. You can also do your Thessaly, and that's actually one that you can do on a video visit with a patient. You don't actually have to be in the exam room, but you can. And so for that one, you'll have a patient hold onto a table or the wall or you and have them stand on their affected extremity and bend their knee to about 20 to 30 degrees and have them rotate to the right and then over to the left and see if they have any pain or catching or locking with that. And then your Apley is the other one that you can do. So for your Apley, you're going to have the patient lying down prone with the knee bent to 90 degrees, and then you're going to push down on the foot and internally and externally rotate it several times, seeing if that elicits pain. So those are all the physical exam maneuvers that I do on my patients where I'm suspicious for a meniscus tear. All right, so next let's talk about imaging. So you want to get your x-rays on all of your patients with acute knee pain and your middle-aged and elder patients as well. So in your younger patients, you get the x-ray really to rule out any fractures. And in your elder patients, you want to kind of assess the degree of degeneration that they have going on in the knee. So in my elder patients, I will typically get the AP, lateral, Rosenberg, and Sunrise views and assess the degree of degeneration or arthritis that I see. And you guys should check out my arthritis video to learn a little bit more about those x-ray views and how to obtain them and what the Rosenberg means. So the Rosenberg does show early evidence of arthritis. So that's why I get those in my middle age for elder patients. And then in my younger patients with typically acute injuries, you can really just obtain the AP, lateral, and Sunrise views because really you're looking for fractures. You can also see evidence of effusion on that as well. So typically these x-rays are going to be pretty normal, which is good, and your patient's going to be pretty happy that they don't have a fracture. So next, we'll talk about the MRI. So technically, in a patient that presents initially for a meniscus tear, you do not have to order an MRI right away. However, if there is any suspicion for a ligamentous injury, you should definitely get an MRI to rule that out. But technically, in acute presentation of a meniscus tear, you don't have to order the MRI right away because technically we can start with conservative treatment for our patient. And if they don't respond to conservative treatment, that's when we typically order the MRI when we're thinking about surgical planning for that patient. So when you do get the MRI, and if you do get the MRI, what you'll see is commonly the meniscus tear and some degree or level of effusion in the knee. You can also see possibly bone bruising or bony edema and possibly a subchondral fracture as well, or impaction fracture. So when you're assessing the MRI, you want to assess several things regarding the meniscus tear. You want to assess the location, the acuity, the type, and the size of the meniscus tear. So you're going to scroll through on your coronal, sagittal, and axial views and be assessing this. So in terms of the location of the tear, this is important to take a look at and assess, because if the tear is more on the periphery or the outside of the meniscus, this area is more vascular. So more healing potential in this area versus the inside of the knee, you typically see degenerative tears or fraying, and that's pretty avascular, so pretty low healing potential there. In terms of acuity, fraying is a sign of more chronic wear and tear versus, and a horizontal type of meniscus tear is also more so commonly seen in a chronic kind of meniscus tear versus some patients with acute knee injuries, they'll have a bucket handle tear. So that maybe is more of an acute type of tear with a lot of effusion on the MRI. And then we're going to assess the type of meniscus tear. So we talked a little bit already about the type. So you can see a bucket handle tear or a longitudinal or vertical tear. And for those, maybe you're thinking about meniscus repair versus partial meniscectomy. Or, you can see a horizontal tear or a radial tear. So assessing the type of tear is also very important. And then finally, the size. How large is the tear? Is it, a little bigger, so greater than 4 millimeters, or is it small? And is it partial thickness or full thickness? All really important things to think about. The MRI views that I commonly look at to assess the meniscus tear are going to be the coronal and the sagittal views. Those are the best to really assess the meniscus. And then the axial, I take a look at to see the size of the effusion and if there's any other injuries that I might be suspecting associated with the patella or the ligaments surrounding the patella. All right, so now you're ready to talk about treatment with your patient. So the treatment for meniscus tears breaks down into conservative or non-surgical and surgical treatment options. And like I've been talking about, we really like to start with the conservative treatment because a lot of times patients can respond well to this option. So we'll start with some physical therapy and bracing. So in physical therapy, we want to make sure that our patient is progressing in their knee range of motion. So initially, if your patient presented with range of motion that didn't look so great, you want to make sure that they're progressing so that their knee doesn't become stiff. They'll also work on isometric exercises, so activating their quads and their hamstrings and the muscles that support the knee, and then progressing as the patient tolerates with proprioception, strengthening, and gait training. So while the patient's in physical therapy, I also like to provide them with a hinge knee brace. And so what this brace is that it has metal on the sides of the brace where basically the hinges are. And that brace provides our patients with more stability to the knee. So when a patient does return to their normal activities, they do have that added support. Also NSAIDs or anti-inflammatories. So if you guys want to learn a little bit more about how to select between our non-selective and our COX-2 selective NSAIDs, check out my arthritis video where I talk all about that. But NSAIDs are important treatment to discuss with our patient because it helps in inflammation as well as pain. And then RICE, so rest, ice, compression, and elevation. I like to provide my patients with an ACE wrap if they have a knee effusion and tell them to wrap it around their knee and apply compression to their knee to help the fluid reabsorb into their body. Also, if a patient is returning to their activity and they were walking or returned to sports and twisted their knee and had an acute flare, they might experience a new onset of swelling in the knee. Sometimes that can happen if you twisted the knee and the tear technically can progress in size somewhat. So the ACE bandage is something that the patient can do to wrap their knee and provide that compression to the knee. Also activity modification, so modifying the activities so that these flares do not occur. So I tell my patient to avoid quick twisting and pivoting motions, also quick deceleration or acceleration, where the patient is loading force onto the joint, can activate a meniscus flare or progress in the tearing of the meniscus. And then lastly, injections. So injections are more common in our middle age or elder patients because they have some degree, most likely, of degeneration as well. So a lot of times I like to tell my patients that they should start with some physical therapy, but injections are definitely an important piece of the picture in treatment for meniscus tears, most commonly in our middle age or elder patients that have more of the degenerative picture. And then finally, surgery. So the surgery that is involved for meniscus tears is a knee arthroscopy. And it kind of breaks down into two main options. So either a partial meniscectomy or a meniscus repair. So the meniscus repair is when we do the arthroscopy. So we place the incisions over the front of the knee and introduce two long tubes into the knee. And the meniscus repair will suture up the tear versus a partial meniscectomy is where we'll do the arthroscopy, introducing the tubes and then shave the tear or any fraying of the meniscus at that time to smoothen it out. So in your meniscus repair, you're thinking about doing this more so in the patients that have a tear that we feel will heal more readily after suturing it. So these types of injuries include possibly a bucket handle tear or a longitudinal tear. So those tears you can suture. Also tears that are more on the periphery or tears in younger patients, and also smaller tears too. Versus the partial meniscectomy is going to be more the option in our elder patients, our complex tears, or our degenerative tears. So the recovery for these types of surgeries are also very different. So in our meniscus repair, we really want to make sure that that meniscus heals. So we're a lot slower in progressing our patient's weight bearing and range of motion of the knee. And typically the recovery is going to be a little bit longer in the meniscus repair with some period of possibly non-weight bearing and the knee locked in full extension. And you're looking more so at around 3 months about for the full recovery of the knee. Versus the partial meniscectomy, we are not so concerned about the meniscus healing because we shaved it off and or part of it off and are not so concerned about it healing back together. So the patient will resume weight bearing as tolerated and range of motion as tolerated to help them get back to their normal function. And then in conjunction with these surgeries, we also can do a chondroplasty, which is basically shaving or smoothing out the cartilage to rid of any irregularities or irregular surface on the cartilage. So that can be done as well at the same time during the knee arthroscopy. So an important thing to educate your patients on when you're talking about surgery with them is that knee surgery, particularly arthroscopy or any joint surgery really, can lead to earlier onset arthritis. So this is another reason where we really like to start with our conservative treatment before progressing to surgical treatment in patients. All right, so these are the most common questions that I get from my patients that have sustained a meniscus tear or injury. So first, will my meniscus heal on its own? And this, we already talked about a good amount actually. Commonly, since the meniscus is a pretty avascular structure, the meniscus won't typically completely heal on its own. There are some prognostic indicators suggesting better healing potential, such as the location, if it's more on the periphery, the size, if it's smaller, the patient's age, if the patient's younger, and the acuity. If the injury was acute, all of those are better prognostic indicators for better healing potential. But since the meniscus is pretty avascular, pretty low likelihood that it'll completely heal on its own. Next, do I need an MRI? So we already talked about this too. Technically, on initial presentation of a meniscus tear, you don't have to get an MRI right away. But in your patients that you're suspicious or questioning a possible ligamentous injury, then you definitely want to get an MRI in those patients. Otherwise, we don't get an MRI right away because we can start with some conservative treatment. And if a patient continues not to respond, then we'll talk about ordering an MRI and possibly order an MRI for surgical planning. And I'll tell my patients that a trial of conservative treatment will be twice a week of physical therapy for about 6 weeks. And then I'll reassess at the follow-up in 6 weeks. And if the patient is responding well and making really good strides, then we can talk about maybe continuing the conservative treatment. And if not, maybe the patient has a more significant tear, such as a bucket handle tear, you might need to get an MRI and think about surgery earlier on. And then finally, do I need surgery? So one thing that we didn't talk about was what's called a locked knee. So some orthopedic surgeons do consider this need for urgent or emergent surgery or knee arthroscopy. So what this is a patient will present to clinic with a locked knee, or basically when you're trying to fully extend the knee will be locked and will lack full extension. So what's happening is that the meniscus or surrounding structures, such as possibly the ACL, most commonly after an acute knee injury, are going to be trapped in the joint space and preventing that full knee range of motion. So this is a consideration for possibly urgent or emergent surgery. Otherwise, we don't really jump to surgery in patients with this injury because likely they'll respond some to conservative treatment, and we want to see how much they do. All right, last really cool factoid that is very common for people to talk about in orthopedics is that 60% of individuals older than 70 were shown to have degenerative meniscus tears, and many were asymptomatic. So this just goes to show a lot of people that are especially elder have meniscus tears, and we really don't jump all over it. We like our conservative treatment, and we like our patients to try it. Okay, so you guys are now pros in taking care of meniscus tears. So make sure you comment, like, and ask me any lingering questions that you may have below. And if you guys want to learn more about ACL tears and knee arthritis, make sure you check out my other 2 videos as well.